Olá, meu nome é Renato, estive recentemente em São Paulo na Jornada Paulista de Radiologia em parceria com o RCNA, os maiores eventos de radiologia e diagnóstico por imagem, e lá tive a oportunidade de conversar um pouquinho com o Dr. Eric, médico, chefe do Departamento de Medicina Nuclear e PET-CT do MD Anderson, no Texas, Estados Unidos, os maiores centros de oncologia do mundo. Lá falamos um pouquinho sobre PET-CT, PET-ressonância, perspectivas de novos traçadores, foi bem interessante. Acompanhe.
What's the importance of PET-CT on oncology and nowadays, in your experience, for oncology, PET-CT?
So we do PET-CT day in and day out in oncology patients, and it's really become an invaluable tool in the evaluation of our patients. I suspect if we told our clinicians we could no longer do PET-CT, there would be an uproar that they, really do rely on PET-CT for all manner of malignancies. Our surgeons in many cases don't want to take somebody to the operating room without getting a PET-CT first using FDG, knowing that it's the most sensitive imaging technique for detection of metastatic disease that may preclude a curative surgery. We've had discussions with our melanoma group that even though PET-CT is not generally recommended for surveillance, they recognize that PET is the most sensitive imaging technique for detection of recurrent melanoma. And the group has actually published papers from MD Anderson showing that it can detect disease anywhere between 3 and 6 months before you would see it on CT scanning. Now the question becomes, does that actually impact patient care? And unfortunately, melanoma being an aggressive disease, oftentimes when they have recurrence, they don't have a good prognosis. They're going to eventually succumb from their disease. And so it still is in question whether you can benefit those patients by going in and taking out those lesions surgically. But nevertheless, we know that if you're interested in detecting disease, FDG PET is the best imaging technique you can use for detection of disease in that patient population. And we found the same thing to be true in many different populations. Now we also use PET as an adjunct to conventional imaging, so it's a valuable tool in addition to CT and MRI, which oftentimes are indeterminate. We perform a CAT scan in a patient with malignancy, we see some findings, we're not sure what they mean. The choice would be to either see them back again in 3 to 6 months and see what it looks like then, or to do a PET-CT now and determine once and for all, is this malignancy, is this something to be concerned about? And instead of then delaying the patient care, we can get on and do what's necessary for the care of that patient. And so in the oncologic setting, FDG PET-CT is really the center of what we do these days in terms of molecular and functional imaging. And as we talked about before, these other radio tracers, as we discover their particular roles and strengths, are going to have similar power. So for example, the gallium-68 somatostatin imaging agents are probably going to assume a very central role in the evaluation of neuroendocrine tumors like FDG is for many other malignancies. But we know that FDG has limitations for carcinoid tumor and islet cell tumor and these, where gallium-68 DOTATOC, DOTATATE, DOTANOC may be a very good imaging test for detection of disease and characterization of disease spread in those patients. So I can't overstate how meaningful PET is in the evaluation of patients in the cancer setting.